So next topic is the trauma and burn. We will start with the type A questions. A 37-year-old man is transferred to the ICU following a motorbike accident. CT thorax shown 1 hour earlier, so fractured rib on left side of chest, severe pulmonary contusion, pelvic fracture. Shortly after arrival in ICU, he develops severe respiratory distress over a few minutes. His BP falls to 80/50 and he develops a tachycardia. First priority would be immediate intubation and ventilation, rapid infusion of 1 liter crystalloid, urgent evaluation of chest for signs of tension pneumothorax, arrange an urgent surgical opinion, nor an infusion. So what is your answer? What is answer? Anybody? B. Everybody answer B. Rapid infusion of 1 liter crystalloid. Okay. So problem is the tension pneumothorax. What is the difference between the tension pneumothorax and the pneumothorax? If pneumothorax associated with the hemodynamic instability, it is a tension pneumothorax, and tension pneumothorax is the urgency. So first priority is the urgent evaluation of chest for signs of tension pneumothorax, and if it is like that, then you have to go with the wide bore cannula or followed by the chest tube. So patient has fractured rib on CT scan, life at risk as a tension pneumothorax, raised intrathoracic pressure, which lead to venous return, reducing cardiac output, hypotension, and reflex tachycardia. So in this case, they have given the hypotension, tachycardia, along with the history suggestive of the fracture rib. So you should think about the tension pneumothorax. Next, regarding the usefulness of ICP monitoring in patient with TBI, which one of the following is true? Outcome is improved in patient who respond to ICP lowering therapies. If the CT scan is normal, ICP monitoring is not required. ICP lowering therapy can safely be given empirically. Cerebral perfusion pressure can be monitored without ICP measurement. Hematoma requiring surgical evacuation occurs as a consequence of ICP monitoring. So which option is true? So this is given answer E. Okay. So E, hematoma requiring surgical A. Somebody has given A. Okay. So answer is A. Raised ICP correlate with the increased mortality in TBI, and patient who respond to treatment with fall in ICP have better outcome. Patient with ICP monitoring has better outcome than historical control, but no evidence. What is the CPP? CPP is the MAP minus ICP. If you don't know the value of ICP, you cannot calculate the CPP. And hematoma requiring surgical evaluation occurs in 0.5% of cases of ICP measurement, most commonly with ventriculostomy catheter insertion. Normal CT brain is associated with reduced risk of raised ICP in comatose TBI patient, but is not highly sensitive. The incidence was 13% in 1/6. So basically answer is A. Outcome is improved in patient who respond to ICP lowering therapies. Okay. So answer is A. Regarding unstable fracture of pelvis, which one of the following option is true? Fall from a great height are the commonest cause of injury. Mortality is as high as 45% hemodynamically unstable patient. Associated intra-abdominal injury is unusual. Pulmonary embolism for pelvic DVT is most common cause of death. Arterial embolization has no role in the management of pelvic bleeding. So which option is true? B. Okay. So B is correct because mortality is very high in hemodynamic unstable patient in a tune of 45 to 50%. And most common cause of serious pelvic injury is the motor vehicle accident. Then fall from height. And mortality with severe disruption of pelvic ring is around 30 to 45% with major bleeding because of the femoral arterial puncture or some vascular injury. So hemodynamic instability is very common. Serious pelvic injury is correlated with intra-abdominal injury, which should be actively excluded. Arterial embolization may be indicated in some cases. Mostly pelvic bleeding venous, so arterial embolization may stop arterial bleeding, while fixation of pelvic ring allows venous bleeding to tamponade itself. So if there is an arterial bleed, then arterial embolization is the treatment. If there is a venous bleed, then just fixation of the pelvic ring will take care of that thing. Okay. And hemodynamic instability is quite common in these type of patients in a tune of 30 to 45%. And the most common cause of pelvic injury is the motor vehicle accident, not the fall from height. It is a second commonest cause. So pelvic injuries, traumatic brain injury, chest injuries, these are very common topics related to the trauma. That's why I deliberately put these questions in this EDIC crash course. Then what is the true statement regarding the anesthetic management of patient with major burn? Awake fiber optic is the technique of choice in patient with stridor. High ventilator minute volume will be required. Intramuscular morphine is ideal supplement. Non-depolarizing muscle action should be given in small dose. Theater temperature should be maintained at 37 degree. So what is the answer? A. Okay. Anybody else? They are asking about the major burn. Answer is B. In a patient with impending upper airway obstruction, a fiber optic bronchoscope may occlude the narrowed airway and cause complete obstruction. So inhalational induction or RSI, rapid sequence induction, are the preferred choice with the experience of anesthetist. Increased CO2 production will be a feature of hypermetabolic phase, and therefore minute volume will need to be increased if normocampania is to be maintained. Morphine, slow onset and long duration of action. Shorter acting opioid is preferable, like L-fentanyl. Absorption kinetics of IM injection are unpredictable, so analgesia should be titrated IV, and large doses of non-depolarizing may be required because burn patients are resistant to their effect from 1 week post-burn. And warm theater is mandatory to prevent heat loss. 37 degrees centigrade will be intolerable for the healthcare staff. So true statement is the high ventilator minute volume will be required because hypermetabolic state is there. And awake fiber optic requirement is the RSI or inhalational induction. And non-depolarized muscle action should be given in the large doses, especially after 1 week post-burn. And theater temperature should be maintained at not at 37 degrees, lower degree, but definitely there is a high chances of hypothermia. So a little bit higher temperature, but not in a tune of 37 degrees centigrade. Then 55-year-old man is admitted to major trauma center following a motor vehicle collision. He is taken to theater for damage control surgery. Massive transfusion protocol was activated. 8 unit packed RC, 8 unit fresh plasma, and 8 pooled doses of platelet. Surgeon has claimed a bleeding vessel, but reported that a surgical field continued to use. Thromboelastogram is performed. R time 10 minutes, K time 3 minutes, angle 62 degree, maximal amplitude 71, clot lysis as 60 minutes 11%. Given these results, what is the most appropriate blood product to administer to improve homeostasis? FFP, cryo, platelet, recombinant factor 7, or tranexamic acid. So this tag is very important. In the exam, definitely they will ask at least one question from tag in any form. In a type question, K type question, or so you should know the normal values of R time, K time, angle, maximum amplitude, clot lysis, time at 30 minutes, at 60 minutes, so that you can give the answer of these questions. So tag, you know the tag, how does it works? It's there is a pin which is immersed in blood and cup is rotated. R time is normal 4 to 8 minutes. and K time is 1 to 4 minutes. Angle is 47 to 74 degree, and the K time and angle measures clot kinetics and the rapidity of fibrin buildup and cross-linking. Maximal amplitude is the greatest vertical width achieved by the tracing and reflect the number and function of platelets. So if MA is low, then you should give the platelets. If R time is high or K time is high, you should give the FFP. So you should know what to give in. So R time is high, 10 minutes. So answer is the FFP. If maximal amplitude is low, then platelet is the answer. If clot lysis is too high, then answer is the tranexamic acid. So you should know which value is abnormal and what are the normal values of the different factors of the different components of the TAG graph. R time, K time, angle, maximal amplitude, clot lysis at 30 minutes, at 60 minutes. Okay. So you should know all these things. Tag is very important. And nowadays they are asking questions from ROTEM also. So whenever you read tag, you should read the ROTEM also. So in the ROTEM, almost same thing, but the terminology is different. There is a intrinsic factor, extrinsic factor, the FibTim, INTIM, XTIM. So you should read ROTEM and tag yourself. But these topics are very important in the exam. A 91-year-old man falls in garden and sustained fracture of the rib 4 to 6 right side, small pneumothorax, which is managed conservatively. No other associated injury. There is no evidence of myocardial or pulmonary contusion. His past medical history include ischemic heart disease, COPD, medication include aspirin and clopidogrel. He is managed on the surgical ward for 24 hours. Then a request is made for assistant with analgesia. In addition to the regular paracetamol and NSAID analgesia, he is already receiving which of the following option would be the best choice for pain management. Paravertebral block, intercostal nerve block, thoracic epidural, Antonox, changes from oral to IV paracetamol. What is your answer? Please give answer. Very important topic, pain management. So one question definitely asked from in the exam, pain management. They can ask questions from medicine like dexmedetomidine, fentanyl, L-fentanyl, morphine. So answer is B, intercostal nerve block. Yes. So this is the right answer. Intercostal nerve block is the choice. I am not going in much detail. So you should read yourself. The pain, delirium and sedation. This topic is very important for exam point of view. Regarding acute traumatic cardiac tamponade, the following are true except it is more common in penetrating than blunt trauma. Jugular venous pressure may be normal. Fall of more than 10 millimeter in systolic blood pressure during inspiration defines pulsus paradoxus. An enlarged cardiac sellout is seen on the chest X-ray. ECG finding of electrical alternance is pathognomic of cardiac tamponade. Somebody has given the answer. This is the answer is B. Okay. The jugular venous pressure may be normal, but it can happen. Jugular venous pressure may be normal. So answer is D. Cardiac tamponade is a rare complication, relatively common in penetrating injuries. Most common presentation of penetrating cardiac injury. JVP usually raised, but may be low in presence of associated hemorrhage outside the pericardial sac. In chronic cases of cardiac tamponade, enlargement of cardiac sellout is usual, but not in acute case, where the low compliance of pericardium leads to the cardiac tamponade. So if cardiac sellout is enlarged, it means this is a chronic cardiac tamponade. Because in acute cases, there is a less chances of to stretch the pericardium, and that's why it leads to the cardiac tamponade with a very small amount of blood. But if process is slow, in a chronic case, this sellout is enlarged. An electric alternance, because of heart swinging with a large effusion, It is specific but insensitive sign. So answer is enlarged cardiac sellout is seen on chest X. Usually in acute traumatic cardiac tamponade, you cannot find enlarged cardiac sellout. And pulsus paradoxus, there is no paradox in this. There is a exaggeration of the normal phenomena. Usually during inspiration, the systolic blood pressure is decreased by 5 millimeter of mercury. But when cardiac tamponade is there, so there is an exaggeration of the normal phenomena. The fall in systolic blood pressure in a tune of more than 10 millimeter mercury during inspiration. This is pulsus paradoxus. So there is no paradox. There is an exaggeration of the normal phenomena. So this is a misnomer, pulsus paradoxus. And it's a more common penetrating injury. Okay, jugular venous pressure may be normal. It may be normal, but rarely, because when there is a associated hemorrhage outside of the pericardial sac. So patient is hypotensive, patient blood pressure is low, JVP may be normal, but cardiac sellout cannot be increased or enlarged in case of acute traumatic cardiac tamponade. It is only when the process is chronic, like chronic cardiac tamponade. So fluid resuscitation, which statement is false? Resuscitation with large volume of crystalloid increase the incidence of abdominal compartment syndrome. Hypertonic saline has been shown to increase survival. Arterial base deficit is better indicator of adequacy of fluid resuscitation. Serum lactate is a better indicator of adequacy of fluid resuscitation. Rate of clearance of base deficit is correlated with survival. So somebody has given answer B. Okay, hypertonic has been shown to increase survival. Obviously, this is false. So we know this thing. I'm not going in much detail because nowadays hypertonic saline or colloids are not used for the fluid resuscitation. So the choice of fluid resuscitation is the crystalloids, or among the colloids, the 5% albumin is a choice. A 45-year-old man with diffuse axonal injury and a GCS of 7 on presentation has been sedated and ventilated on your ICU for past 24 hours. He has no other injuries of note. Intracranial pressure monitoring has not been instituted. Which one of the following statement is true? PEEP is contraindicated. PaCO2 should be maintained at 4 to 4.5 kilopascal. Whenever there is a kilopascal, you should multiply with the 7.5. Thiopentone is the sedative agent of choice. Plasma osmolality should be kept below 320. Mean arterial pressure should not exceed 90 millimeter mercury. So what is the answer? Which statement is true? So answer is D. Plasma osmolality should be kept below 320. So this concept is very important to understand. When we use mannitol or 3% hypertonic saline for lowering the ICP monitoring, so our maximum osmolality which we can tolerate is the 320 milliosmol per liter. So we should not go beyond that. So PEEP may be used especially in hypoxemic patient. PaCO2 should be maintained between 4.5 to 5 kilopascal. Lower level may cause cerebral artery vasoconstriction and so compromise cerebral perfusion. Thiopentone has high fat solubility and long elimination half-life, so increased risk of nosocomial infection. It is not the first choice, although it remains a therapeutic option in case of refractory raised ICP. Okay. So administration of mannitol or hypertonic saline usually we use as a therapeutic maneuver in case of raised ICP. But plasma osmolality should be measured and should not exceed more than 320 milliosmol per liter, because after that there is a neurological as well as renal side effects. So again, an important question. Trolley, we have discussed this question, but again, volume overload is the principal problem. Mortality range is 5 to 25%. Immunological diagnosis, IG mediated. Trolley is physically distant from acute leg injury. We have already discussed this question. So answer is B. It is a clinical diagnosis. So it's not immunological diagnosis. Mortality 5 to 25%. So now we move on the K-type question. If you want to ask any question, you can ask. So a 44-year-old man is involved in a road traffic accident, admitted to the ICU following fluid and blood resuscitation. Emergency splenectomy, external fixation of pelvic fracture, and external fixation of femoral shaft fracture. Initial presentation in ER, he was in ATLS grade 3. An ABG showing lactate 6.4, an arrival in ICU that lactate reduced to 3.5. So this patient has a type A lactic acidosis. Lactate is a prognostic significance. Venous blood can be used for lactate analysis. Outlook will be poor if lactate remains above. So what they are asking, which statement is true or false? So if they are not asking anything, so we should presume that this is sorry, K-type question. So this is K-type question. We should tell about each and every option. So type A lactic acidosis, this is true. Lactate is a prognostic significance. Yes. Lactate is high and lactate is not decreasing trend. So prognosis is poor. Venous blood can be used for lactate analysis. So venous blood can be used for three things in the ABG. One is pH, another is bicarb, and third is lactate. So you can use venous blood as a replacement of arterial blood for looking three things in the ABG. One is pH, another is bicarb, and third one is the lactate. So this option is correct. Venous blood can be used for lactate analysis. Outlook will be poor if lactate remains above 2 millimole per liter after 48 hours. Obviously, we expect that lactate, if remains above after 48 hours, then prognosis is poor. Next is 30-year-old woman present to emergency room following a suicidal attempt. She has been in an enclosed space, burning coal, fire, drowsy, GCS 13, heart rate 123, BP 125 by 95, oxygen saturation 96%. She has a brief GTCS, pH 7.36, PO2 308, and calculated SaO2 99%, and PCO2 33. The history and finding are consistent with carbon monoxide poisoning. There is evidence of a saturation gap. Oxygen therapy should be titrated down to a lower PCO2. Hyperbaric oxygen therapy is contraindicated. So you have to tell for each and every option. True, false, true, false. Anybody? So history and findings are consistent with carbon monoxide poisoning. Accurate, yes. Second is, somebody has told that TTFF. Okay, but T at triple F. Because second was that there is evidence of saturation gap. So for saturation gap, the gap should be more than just measured in this true SO2 will be lower when compared to the falsely added SPO2. This is termed saturation gap. So saturation gap is less than 3%, I think here. 96% and 99%. If it is more than 5%, then only you can say this is a saturation gap. Otherwise, not. So there is a difference of only 3%. So indication for hyperbaric oxygen therapy includes pregnancy, carboxyhemoglobin more than 20%, neurological signs, and loss of consciousness. So they asked this question, what are the indications of hyperbaric oxygen therapy? So what is the contraindication of hyperbaric oxygen therapy? Can anybody tell? Pneumothorax. So pneumothorax, you cannot use the hyperbaric oxygen. A 28-year-old man receives a stab wound to the upper abdomen. On arrival in emergency room, he has a GCS of 15, pain, a small puncture wound under the left costal margin, BP is 80 by 40, heart rate 130, respiratory rate 30. Neck veins are distended, chest X-ray shows no evidence of pneumothorax or hemothorax, ECG showing right bundle branch block, and T-wave inversion lead V1. Focus abdominal ultrasound, fast scan shows the presence of pericardial fluid. So transthoracic echo is a diagnostic choice. when considering traumatic cardiac tamponade as a diagnosis. CT thorax should be performed immediately. Rapid fluid infusion should be avoided to prevent right heart failure. Removal of at least 300 ml fluid is required to materially improve the clinical condition. So what is your take? Somebody TFTF. Okay. Anybody else? So only one option is true. Transthoracic echo is the technique of choice because it is fast and sensitive. CT scan is likely to be hazardous for this patient and will not alter the need for decompression of pericardial sac. IV fluid is required to try and maintain right heart filling and cardiac output. Removal of as little as 30 ml fluid may give dramatic improvement. Immediate thoracotomy is not mandatory, although it may be the management of choice in cardiothoracic center and is indicated in the event of deterioration or cardiac arrest. So among these options, only one is correct. Transthoracic is the diagnostic, echo is the diagnostic choice. CT immediately to confirm, no. Rapid transfusions should be avoided to prevent right heart failure, no. And removal of at least 300 ml, no, only 30 ml is sufficient to dramatic improvement. Then 34-year-old man is involved in a car accident at high speed. He's the driver and wearing a seatbelt, neurologically intact on arrival in emergency room, but hemodynamically unstable and has a positive diagnostic peritoneal lavage. He also has bilateral closed femoral fracture. He is taken to the operation theater for emergency laparotomy. Definitive surgery must be performed before transfer to intensive care unit. Surgical stabilization of femoral fracture should be deferred until a later date. Hollow viscous injury must be dealt with immediately, and abdomen must be closed to prevent overwhelming sepsis. What is your take? Overwhelming sepsis. What is your take? TTFF. Okay. TTFF. You can write also in chat box. So answer is FFTF. I think there is some. Please mute yourself, Susmita. So answer is only C option is true. Hollow viscous injury must be dealt with immediately. Definite decision must be performed before transfer to ICU. Surgical stabilization should be deferred until later date. No. Abdomen must be closed. No. Abdomen should not be closed because there is a chances of the abdominal compartment syndrome. So this major polytrauma cases are very important, and you should read all the ATLS guidelines to see how the polytrauma case is dealt. So there is a role of the damage control surgery. There is no role of definitive surgery in a first go. Second thing, patient abdomen should not be closed because of the high risk of abdominal compartment syndrome. And blood products, how should be given before the operation theater. So you should know each and everything in detail of the advanced life trauma support, ATLS. A 32-year-old woman suffers a liver laceration on a road traffic accident during laparotomy. She bleeds extensively and requires a 15-unit blood transfusion. Post-operatively, she is transferred, ventilated to the ICU. She developed progressive worsening lung compliance and hypoxemia. Chest X-ray shows widespread fluffy infiltrates. PaOP is 15 millimeter mercury. Chest X-ray may be consistent with pulmonary edema. Diuretic therapy is indicated. Corticosteroids are indicated. Sufficient information is available to diagnose TRALI. So, what is your take? You can write in chat box. So, FTFFT. Okay, your answer A and D are correct. Okay. So, write this TFFT. This is TRALI caused by infusion of blood product. Donor antibodies target the host leukocyte causing complement activation. This is the pathophysiology of the TRALI. This is a clinical diagnosis, so no need for any immunological diagnosis or some test. In decreasing order of potential to cross trolley, whole blood FFP, packed RBC, whole blood and FRS concentrate, diuretics and corticosteroids are not of any benefit. So corticosteroids and diuretics should not be given for the treatment of Graves. So we are stopping here. This is the class of trauma and burn.